Okay, so we'll make a start. Welcome everyone. My name is Annalise Morris. I'm one of the team members here at Health Translation SA. Just before we make a start, I'd like to acknowledge that I'm meeting on the lands of the Kaurna people, and we acknowledge their spiritual relationship with their land. Having trouble with my slides. Good start. We haven't even, look at that. There we go, acknowledgement. As I said, I'm meeting on the lands of the Kaurna people, and we acknowledge them as the traditional custodians of the Adelaide region, and recognising the Kaurna people's cultural, spiritual, physical and emotional connection with their land. We also honour and pay our respects to Kaurna elders past and present, and all generations of Kaurna people now. I'd also like to acknowledge the lands that some of you may be meeting on if you're outside the Kaurna area, and also welcome any Aboriginal Torres Strait Islander people that we have joining us today. So today we are in webinar 3 of our Implementation Science series here at Health Translation SA. In addition to our webinars, we're also sharing a number of other resources, links to training programs, videos, publications and reports. So if you'd like to hear more about the topic, please email us at inquiries@healthtranslationsa.org.au and we'll add you to our mailing list to get all of the other resources that we're sharing. Coming up today, we have Tahna Pettman, Ecushla Linedale and Peter Hibbert sharing 3 separate presentations for us as we go along. So we'll jump straight in briefly. I know a lot of you will be familiar with Health Translation SA, but just to quickly summarise, our purpose here, being an accredited translation centre, is to accelerate research findings into healthcare and also to increase whole of system research translation capacity. So that's really what this Implementation Science series is all about. It's to build up the knowledge and the capacity across our system in health professionals and in researchers in implementation science, with the end aim to be improving the health of all South Australians. So I will hand over fairly promptly to Tahna Pettman, who's going to kick us off today. So Tahna, I'll let you get your slides up there. Dr. Tahna Pettman is passionate about public health, health promotion, primary prevention, equity, and has expertise in knowledge translation, research impact and evidence-informed decision-making. Tahna currently works in academia at University of South Australia and Flinders Universities on a linkage partnership project to support the translation of principles within the food relief sector in South Australia. And Tahna also works in consultancy, providing research, evaluation, knowledge and translation. So as you can see here, Tahna's going to share with us about using implementation science and knowledge translation in policy and practice. Take it away.
Thanks, Annalise. They're all my favourite things. Now, can you tell me, are the slides viewing okay so far?
Yes, yep, they're up correctly. Thank you.
Excellent. Thank you. And look, thanks for the invitation to join in on this very timely webinar series. It's important that I begin first by also acknowledging that I meet you today on Kaurna land. I acknowledge their continuing connection to the lands and waters, and acknowledge that sovereignty was never ceded. And I want to pay my respect to elders past, present and emerging, and welcome all First Nations people here today. Now, while I was trained and a bit more engaged in implementation discipline about a decade ago, when I was a research fellow at the Uni of Melbourne, I've since worked more in postgrad teaching, policy, consultancy and raising a young family. But I've continued to apply the principles that I learnt back then and the sorts of concepts and constructs from implementation science to my policy and evaluation work. So I've recently returned to a research role at UniSA and Flinders, and I'm really enjoying revisiting implementation science in a research context. So today I'll share a few of those examples from the different parts of my career and try, if I can, to illustrate how this very rapidly emerging field can be quite useful for practice and policy. So this is what I'm going to talk about today. To do this, I'll be drawing on my experience in my knowledge translation research and time at Cochrane Public Health Review Group. And that was really around focusing on evidence-informed public health decision-making. I'll draw a little bit on my training in implementation science and the networks that I've developed as a result of that, and now a current role I have on the editorial board of Implementation Science Communications. And as well, drawing on some of the work I've done in state government and for NGOs, and certainly from stakeholders, that's generally who I learn a lot from. Can you see the images there okay? Are the slides working all right from your end? Thanks, Annalise. So look, I wanted to begin first with a little story, I suppose, to illustrate how implementation science caught my attention. At the time, I was working with Victorian local governments, practitioners, decision makers, in a knowledge brokering intervention that was part of a cluster randomised controlled trial. So I was sort of the knowledge broker there to support evidence-informed practice and decision making in municipal public health planning. Now, at the time, complexity science and systems thinking was really gaining traction in public health, and to some extent policy design in Victoria. And it was already really clear that we can't solve simple public health problems with complex public health issues with simple solutions. And I'm going to borrow a metaphor here from Professor Diane Finewood from Canada. And she's a thought leader in complexity science and public health. And this metaphor really helped me to distinguish between simple problems, complicated problems, and complex problems. And it really made me see how implementation science can help with that in terms of evidence generation. So we can think about complexity by describing baking a cake, sending a rocket to the moon, and raising children. So baking a cake, generally fairly simple, follow the recipe, you're usually successful, and you don't really need specific expertise, depending on the cake. Sending a rocket to the moon is complicated. It needs specific expertise, like astrophysics, requires trial and error. But once you've done some experimentation, you can be successful. But when raising a child or multiple children, it's not straightforward. You can't necessarily transfer what you've learned from one child to another, particularly if you had a multiple birth like I did. And the expertise doesn't always help. The context matters a lot. And the sort of expertise that you need is understanding of the context in which you're raising the child. I think the same is true of public health. So take the issue that I was working on at the time that I met implementation science. That was evidence-informed obesity prevention. So what's simple? Empowering an individual with healthy diet and physical activity knowledge, that's fairly simple on paper. Reaching subgroups in a population to ensure equity and cultural appropriateness in implementation is more complicated. But with specific protocols and targeted programs, you can generally achieve that. But preventing obesity across a whole population, which is what we were trying to do in our work, is complex, particularly in the face of aggressive food marketing, suboptimal urban planning environments. It's more complex. And I think health promotion history has taught us that non-communicable diseases and overweight will continue to rise even in the face of individual behaviour change interventions going on. We know the commercial and social influences are really strong. This is complexity. And this is what I think implementation science does really well in a practical way. Because we've got this mountain of evidence available, haven't we, about all the challenges, the solutions. We've got a bunch of information about effective interventions in public health and in health services. And, the people here today are probably using this evidence in some way, shape or form, whether that's in decision making or in your research or program planning. So whether you're a researcher, evaluator, practitioner, advocate, decision maker, you will have generated or used information from, evidence in some way. But that's just the tip of the iceberg, because of course underneath there's all those individual level, organisational and systemic societal barriers to evidence-informed practice, a bit like I just described just before in my example. There's also limited evidence on, that's auto-advancing. There's also limited evidence about what strategies are effective for using research, getting research into practice, getting clinicians to use guidelines. That's the science is starting to catch up in this area. But when I began working in knowledge brokering, this became really obvious. So, how do we work through these barriers to decision making and how do we get evidence used? And if you're interested in the research on research use, that sounds really nerdy, but these are some of the reasons that I was alluding to. So, the common barriers around using research are, as you would expect, availability and access to evidence, the clarity, the timing, not having the skills, all those extrinsic and intrinsic factors that I spoke about, even down to just resourcing, and lack of clarity and recommendations. On the other hand, of course, there's a bunch of evidence about what enables evidence-informed practice in health. And that's, awareness, familiarity with the evidence, relationships between scientists, decision makers, the skills to actually find, use, adapt and appraise research, the key messages available, plain language options for evidence, and collaboration between policy and research. So these are all empirically driven factors. And it sort of helps us think about where implementation science steps in. We know that it's not enough to have evidence. We know that having an evidence-based intervention doesn't mean that it will be translated into practice, and doesn't mean that even if we can, whether that can be scaled up. So this is where implementation science steps in. Now, while I was developing some training and research on evidence-informed practice in the knowledge translation work that I was doing, I was really fortunate to be selected into the Training Institute for Dissemination and Implementation Research in Health. That was over in the United States. And this really helped me gain some fairly concrete knowledge of that emerging field of implementation science, and a much better appreciation for the complexities in research that promote the integration of research findings into policy and practice. Because that's really, I guess, if you think about implementation science overall, and you've probably seen lots of versions of these diagrams over the past sort of few weeks of this webinar series, but the way that I like to think about it is that implementation science is really anything that's a scientific study of the methods that promote the systematic uptake of research findings and evidence-based practices into routine practice. So that's really where I've landed in terms of how I understand implementation science. And for those of you who identify as researchers or evaluators, perhaps have a think about where your work fits. I'm going to give a few little examples of the different types of implementation science. And look, if you're not in a research setting, if you're sort of more in practice or decision making, see if any of the following descriptions resonate, and think about how the terms are used in your organisations, if at all. So the first one I wanted to just touch on really briefly is translational research. I think this has probably got the longest history, and it's really about how that gap research, how we translate research into practice and policy. And I like the framework from Ian Graham and colleagues that looks at, that T1 to T4, going from unmet need through to discovery, to innovation, to practice, and then to impact. So that's sort of looking at gap research. And I guess that's your traditional bench to bedside type work. I haven't so much been involved in that area. I've probably dabbled a little bit more in implementation research, which is research that seeks to understand the processes and the factors associated with uptake of evidence-based interventions in a particular setting. That setting might be a community, it might be healthcare, it might be a work site, it could be schools. So any setting at all. It's really focused on how we adopt, replicate, disseminate effective interventions. And I guess if you go through some of the key features, or what I've gleaned from both my training and doing some of this research, is that it's about the factors that affect implementation, and really looking at how we can successfully integrate evidence-based practices in a particular setting, whether or not the core components are actually transferred into the real world once they go from a research environment. And really that involves much more thinking about context and creation of organisational or community readiness. And some of the outcome measures in implementation research that you might see, and that I've used a lot in my work in evaluation, have been acceptability, adoption or uptake, appropriateness, feasibility, reach, cost, sustainability, and so on. there's some really nice papers from the people that trained me in implementation science about what sorts of outcomes we measure in implementation research. The last one I wanted to touch on was my favourite thing, which is knowledge translation. And that's a practice and a science. The science is starting to catch up around that, but really I guess the common definition would be the synthesis, dissemination, exchange, and ethically sound application of knowledge to improve health. So really that's about methods, the sorts of strategies that we use to get evidence used in decision making. And that's something that I've been working in for probably a decade or so now. Some examples of the work that I did that I suppose you could call knowledge translation research and evaluation includes the local government study that I mentioned. So there we worked with 14 local governments in an interactive way in a knowledge brokering intervention. And we had 14 local governments as our comparison sites. And that was randomised. And really we were working, well, I was working quite individually with decision makers, practitioners that were working on municipal public health and wellbeing planning. And we were really trying to tease out there and understand what the factors were that were actually going to support their use of intervention evidence in designing their public health plans. So that was a really useful study. And I think what we learned, or probably the key finding, is really that culture is king. We were very, it was difficult to make change, obviously, if we weren't able to influence the organisational culture in terms of evidence use. It was very difficult, obviously, for the practitioners, even with all the skills in the world, to use the evidence. It was very difficult for them to actually make change in the planning process without having that senior management or counsellor level support. The other knowledge translation practice that I helped to evaluate was a platform called the Co-ops Collaboration. It was the collaboration of obesity prevention sites. And really this was a national network. It was really just a network for information sharing, but behind that, we embedded some knowledge translation strategies to support practitioners who had funding for healthy communities initiatives to use evidence in their practice. And again, we were able to evaluate that across a range of different settings and at different levels. And again, I guess similar sort of reflections were that, of course, we needed to have much more systematic ways of using evidence in order to see that in practice and decision making. So it's complex. Another example of something that came out of my work through the training was a survey, a national survey that we did with 4 investigators from 4 other countries and worked directly with public health practitioners and managers in understanding some of the barriers and enablers, I suppose, of implementation of evidence-based practice and specifically chronic disease prevention. So again, some really interesting lessons learned there about the different cultures, the political climates, and just general experiences of decision makers in terms of how we find, appraise, adapt and use evidence. And certainly some very distinct differences between the 4 countries, which were Australia, the United States, China and Brazil. And that was a really lovely collaboration between some of the faculty and members that I actually met at the institute, the TIDA Institute. So some really interesting lessons for me there. And the other thing that I've gained over this time is really some networks, and that's where a lot of, I guess I would get a lot of my information even given that I'm a bit of an evidence nerd and always jump into the science first. But there's been some really great networking and information sharing, I think, over the past decade or so in implementation science. It's a really exciting field and great to see lots of exchange across all the different Australian and international practitioners. So I had a little bit to do with the biennial Australian Implementation Conference back when it began in 2012. It's sort of now evolved a little bit more into the Evidence and Implementation Summit, which again is a really fantastic forum and hosted now by the Evidence and Implementation Group. So that's one to keep an eye out for if it's something you're interested in. I find that it's been really useful in broadening my understanding of different disciplines and sectors because it's focused on sort of general social services, public health, child protection, so really wide education, very diverse group, connect and share in that forum. The other place where I've sort of remained connected to this field and actually have learned a great deal was from some of the emerging science. So I sit on the editorial board of Implementation Science Communications. And it's really great to sort of sharpen my knowledge in terms of some of the theories that are emerging and how these can actually apply to different types of practice. You know, I reviewed one recently that looked at using one of the implementation science theories to looking at scale up of diabetes prevention programs at the community population level. So this is a really nice journal to keep an eye on, that as well as the BMC Implementation Science, which is sort of the parent journal connected to this one that I'm on the editorial board for. I wanted to also give a couple of examples of how I've been using these frameworks. And look, if you've dabbled and looked into the literature, you'll see that there's literally, you know, hundreds of implementation science theories and frameworks, which I personally find really overwhelming, even with a research background. But I think what it offers us is the ability to go through and find the appropriate theory that can help us instrumentally in policy design, and particularly for me in evaluation. So over the past couple of years, I was working in the public sector in Wellbeing SA in close collaboration with the Department of Human Services. A public health partner authority agreement exists there, which enables those two sectors to work together on an issue where there are potential co-benefits for the population. So the example I'm referring to is food security. And there was an opportunity that presented itself at the time to pilot a social supermarket. Some evidence had emerged. I was sort of part of a social supermarket scoping review looking at this model for dignified food relief across Europe and the UK. They're very common, but certainly not common here in Australia. There's probably only one or two examples, but really a promising example for building pathways out of food poverty, supporting people with the underlying determinants of food insecurity. So how did we do this? Well, the first thing was that we formed a practice policy research working group. So a cross-sectoral arrangement and cross boundaries really, because we had academics as well as us that were in the public sector, as well as the practitioners from the food centre in Jepps Cross that were an emerging social supermarket. The sorts of, I guess, constructs that I was able to integrate in that planning process was things that I probably did learn from implementation science training. So development of a logic model, which is a clarificative process, doing an analysis of the current practice. So we actually tasked practitioners with that in a participatory manner so that they were doing like a SWOT analysis of barriers and enablers to best practice implementation. We then realised actually, as a collective, we didn't even know what best practice implementation was for a social supermarket, despite having some of the evidence. It's not strong. And so what we did was developed a rubric and incorporating the evidence, the values of the practitioners and the South Australian Charter for Food Relief, we were able to develop a tool that would help practitioners make judgments about what elements of a social supermarket they could implement in their food relief service. And I helped to lead the evaluation plan, and there I very much drew on some of the implementation science outcomes, such as reach, delivery, cost, adoption, applicability and potential sustainability of a social supermarket in South Australia. As it was only a short-term funded pilot, we really needed to know as much about the implementation as possible. So what I didn't do this explicitly. I think it was more tacit, like on reflection, you know, I sort of implicitly use those sorts of constructs to help guide my thinking. And I can't say that at any point I stopped and went, oh, what implementation science theory am I using here? But I reflect now and see that actually these constructs are really relevant. We've also continued to use those now in my new role, which is back in research, and I'm leading an Australian Research Council funded linkage project to translate the South Australian Food Relief Charter principles into practice. And to do that, we're working with 3 different food relief models. 1, the traditional charitable model of a parcel or pantry, 2, the food bank food hubs, and 3, the social supermarket that I just mentioned. So I would consider this pre-implementation, if I had to put it in a box, because really what we're trying to do is understand context. So we're trying to look at, the South Australian Charter was released 3 years ago, very passive in terms of how it's been disseminated. It hasn't been actively implemented. So we're really interested in speaking with the South Australian food relief sector about how those principles can be enacted in their practice and how that can help them improve practice, for example. So we're going to be looking at barriers and enablers of translation to practice and to co-design metrics for monitoring good practice in South Australian food relief sector. And again, if I want to put it in a box, I suppose the sorts of theories that we're using quite deliberately actually would be social inclusion and commensality, probably an element of diffusion of innovations theory. We're certainly using co-design and participatory action research. We want to do things with the sector, not to them or write about them. And in terms of the partnership that we've got here, it's practice, policy and research. And so we're using integrated knowledge translation really to guide the way we manage the partnership over the next 3 years. The sorts of methods that we're using are interviews, co-design sessions with the food relief providers and participatory methods. And that's really about testing new ideas and tools together. And we hope that in future, when we do an implementation research project, that will help enable adoption because we have understood that context very deeply. Last point that I wanted to make is that implementation science, I think, is really useful for evidence reviews too. So if there's anyone out there today that's an evidence reviewer and you're trying to understand these questions like what works for whom, at what cost, under what conditions, definitely go to implementation science. And particularly if you're working in public health or in social services, for example, I think there's a lot that we can learn there from implementation science. And there's some great resources, I think, that have developed by Cochrane over the years. They have a qualitative and implementation methods group now that gives some really great advice for systematic reviewers, as well as some knowledge translation guidance that I was privileged to be a part of helping develop, that sort of evolved over the years in terms of giving some really practical advice for systematic reviewers and how implementation science can be of value. So thank you for your attention today, and I'll stop sharing my screen now. Hand back to you, Annalise.
Thank you, Tahna. That's great. I think you've given us a really nice sort of overview of, and we've touched on it in several of the webinars so far around, this key message around the context being just so vital in implementation science, and when we're looking at what strategies are going to be useful. And I think it's an interesting point you made there in terms of the organisational culture, when we're looking particularly in that public health sort of sector, but in all contexts probably too, as as one of the big big barriers to overcome, or enablers if you're getting it right. So thank you. And just on the Evidence and Implementation Summit, one of the resources that we've shared through this week under the Spotlight program was the workshop report that came out of this year's summit. So if people are interested to learn a little bit more, they can drop us an email if they didn't already get that link, and we can share that, because there's some interesting insights. So thank you for all of that. I'll hand over now to Ecushla Linedale, who's another member of our team here at Health Translation SA. And Ecushla is our digital health program lead and currently looking after our learning health systems projects. Ecushla has a PhD in medicine around healthcare service design and delivery, and experience in basic and clinical research translation, project management and strategic development. Ecushla is really interested in engaging and connecting clinicians, researchers, consumers and industry to pragmatically use evidence to inform and test solutions to real world problems. So Ecushla is going to give us a couple of case studies here from translational research. So I'll hand over now to her. Thank you.
Fabulous. Thanks so much, Annalise. Now, are you seeing my correct slide or my cheat notes? Perfect. Look, thank you so much for having me here today. I think what I'm really hoping to do is give a bit of a case study about one project that we're involved in and how I've approached this using the principles of implementation science. And I'm mindful of the fact that I am sandwiched between two experts in implementation science. So what I'm really hoping to do today is target those of you who may be at the beginning of your implementation science journey and who may be just starting to look at all these frameworks and wondering, how on earth do I begin this journey?
Will it make a lot of noise or not? That's right, I'm on mute anyway, so all good. Yeah, no problem.
Only about 20 minutes.
Yeah, no worries.
Please.
I'll just jump in. I think we've got somebody's come off mute in the background, so I'll just ask everyone to check their mute buttons if we can. Thank you.
Thanks, Annalise. So really the take-home message that I hope you grab from this presentation today is really, you don't have to see the whole staircase to take the first step. Don't be bamboozled by the 180 or so frameworks that are out there. The principles of implementation science can be applied to every health and medical research project that's particularly looking at targeting behaviours and changing them. And so wherever you are on this staircase, whether you're right at the start going, I really don't want to know about this, or maybe you're closer to the top going, yep, I can do this and I'm almost there. I'm hoping that you might be able to learn from a bit of my journey recently through this project. So the project that we're looking at today is the Carlin Prehab Project. Now, this is a project that's led by the surgery team at the Royal Adelaide Hospital and the QEH, and Professor Jane Andrews is the lead. And really, this project is aiming to design and test a digitally enabled prehab model of care for patients who are referred for planned surgery. So what they're trying to do is really make sure that the patients that come in for elective surgery, that's not super urgent, so there's time to plan this, have the best possible opportunity of coming out the other side of surgery and regaining their health and their quality of life as quickly as possible. And the way they're going to go about this is making sure that they're as healthy as possible going into surgery. So really my role in this project has been to provide some project management around this and also apply some implementation science support, and our whole team is involved in different aspects of this project. And really what I want to talk about today is how we applied this implementation science lens to this project to take something that actually is a really good idea and then test those assumptions that are underpinning this good idea and validate the things that the team thinks will work to really strengthen the project and make sure it has the best possible chance of not only being implemented well, but being effective. And that means addressing as many of the barriers that we can right from the front end. And this in itself will reduce the time it takes to actually translate this into something that's embedded in, everyday routine practice. So really for me, when I'm looking through an implementation science lens, I'm thinking about, well, what's the actual problem? Who's it a problem for? How big is the problem? What evidence do we have to actually contribute to solving this problem? And what's the strength of that evidence? And then, of course, we need to think about who are the people that we're asking to change their behaviours, who's affected by this problem, and then what are the barriers and enablers to actually introducing this evidence into practice. And then obviously we've got the implementation strategies which look at targeting those barriers and really harnessing the enablers, and then evaluating not just the effectiveness of the intervention clinically, but actually the effectiveness of the implementation. So that for this project, it's going to be tested in Carlin, but what are those core features that are required for it to be rolled out in Salin or Narlin or Country SA as well? So before I launch into this, there are heaps of frameworks out there. But here's two articles that really helped me as I started on this implementation science journey. And Elizabeth Lynch and Jill Harvey's team at Flinders have written a great article, which is a really useful guide for anyone beginning their journey in implementation science and trying to work out where on earth do I start and which of these frameworks and models are relevant to me. And then I've added this diagram in as well, because this is actually a framework of the frameworks, which is also quite useful because it helped me categorize all the frameworks that are out there into discrete areas that I need to know about. So today I'm going to talk about, I think, a process model that we've used in this project and a determinant framework. And then the next stages of our project will be looking at the actual implementation theories and the evaluation frameworks. So the first model or framework that we actually used was this knowledge to action cycle, which, you know, probably a lot of you are familiar with. And I used this model to really guide the process of the audit and made sure we were able to tick off those areas and make sure we're really addressing everything well. So the first thing was to actually have a look at the problem. And I guess we can never underestimate the value it is of taking the time to really look at what is the problem and who is it a problem for. We all have great ideas and we have awesome solutions, but no matter how good we are, it always pays to take that step back and just really stop and think, okay, how big is this problem? And will me addressing this problem with, you know, whatever solution we've got in mind actually make a tangible difference for patients? And will it be a big enough difference for the health system to want to use it across the entire system? So we had a look at the problem, and then we were going to adapt the knowledge that we have to the local content. And just as a bit of background for you, the specific problem that this team is looking at is post-operative complications. And in elective surgery, we know that they're really common, and about 1 in 5 patients will have a complication in surgery. And this not only affects their recovery, it affects the length of stay in hospital and their return to, you know, their normal quality of life. And of course, it leads to a greater risk of being readmitted to hospital. And not only does it affect the patient who's come into hospital and being operated on, but then there's obviously flow-on effects in the system and to all the other patients that are waiting for surgery as that bed base is filled up with people who are remaining in hospital when they didn't actually need to go through this complication. So this is a big problem because these complications are increasing at a rate of 10% per year. And another team at the RA last year held a national summit called the Hidden Pandemic of Post-Operative Complications. It was held before pandemic was the buzzword. And they were really looking at how we begin to address this problem, because if it keeps increasing at 10% per year, it's completely unsustainable for the health system. And so the team knows from, you know, they're all the clinicians and the surgeons, they know that there's a large body of evidence out there that says, you know, if you can get people as healthy as possible before surgery, you really reduce their risk of having these complications, you know, weight loss or weight gain, quitting smoking, checking that your pain is under control and your iron levels, and a whole heap of things that can be looked at. And these are modifiable risk factors. And there's evidence for each of these, but nobody's actually wrapped all of these together and said, okay, let's look at trialing a global or a comprehensive prehab program and see if we can improve the health of people going into surgery. So what this team has done is taking that the knowledge about the problem and the evidence, they've then looked to see how they can contextualize that to this local LHN. And when a patient comes in for surgery, we can see that, you know, this purple end is an undefined length of time. So from the point at which your GP refers you to see a surgeon in the outpatients department in the public system, that's really a months to years waiting list for most people. So there's this massive gap of time at this front end of a patient's surgical journey, which is really a missed opportunity, and an opportunity that this team wants to target in order to improve health before surgery. They're also building this based on their existing knowledge. So they've shown that in IBS, they can send out questionnaires to patients and they can screen them once they've been referred, and they can gather extra information that will help them really decide whether they need to be seen earlier or later, or be seen at all. They've also trialled a system where they get information back to patients and GPs via a website, and showing that that's feasible and acceptable and is used by both patients and GPs. And recently they've rolled out a digitally enabled colonoscopy health assessment tool, like an e-health pathway. And this is where patients, get a health assessment questionnaire via text, and they fill out all their information, comes back into the system, and the person that's managing the waitlist can have a look there and see, what are the red flags, what needs to be followed up, and it can really streamline the whole process. So I'm not going to go into details about what they're proposing, but basically it is a digitally enabled prehab pathway where they'll be sending out some screening questionnaires to patients, some information to both GPs and patients about how they could think about getting healthier before surgery. And then they'll follow this up with some targeted information on the basis of the different results that have come in from the people who are being referred. And in the bottom right-hand corner here, you can see a website that they're building to house some information to really help GPs and patients start that discussion and tailor a prehab program that works for them. So having done that work, one of the things we really wanted to do was, now you've got this model of care that they want to trial. We want to know, well, what are the barriers to actually doing this? It works from the hospital system end, but what do patients and carers think? And what do the GPs and the practice nurses think, who are actually going to have to implement that? So with the next step in this K2A cycle was really assessing those barriers and making sure we tackle as many of those as we possibly can in this project. And this is where I went and found another framework, the Action Actor Context Target Time. Isn't that an original title for a framework? But basically, this was a lifesaver because it really helped me get some logic around this and to clarify what were we trying to achieve, what behaviours were we trying to change across all the different levels of the healthcare system. And I'm just looking at time, so I'm going to just flick through it a bit quicker for you. But this framework, really, it enabled me to think about who are the actors across the system. So we had the hospital triage staff and the surgeons. We've got the GPs and the primary care nurses looking after the patients in the community. Then we've also got the patients themselves, and we're obviously going to target behaviours for all of these different groups. So I was able to step through this, and if I just pick one column, so for GPs, what we're trying to change is we actually really want them to do a prehab review with their patients. We want them to sit down and have a conversation about the importance of being as healthy as you can before you go into surgery. The context of this is obviously in their GP consultation. The target is every patient that's referred for surgery, so not just ones they think are high risk. As soon as they refer someone off, we would like them to have this conversation. And the time when this is performed, well, possibly it might be a special consultation and not a normal one. But I wanted to show you this because it's a really useful framework for actually thinking through what are you trying to change, where, who needs to be involved. And then this framework can be used to help inform our implementation, evaluation at the end, because all of these behaviours need to be measurable. This is just a quick resource. If you're interested, I saw this blog the other day and I'll flick straight through that because Annalise can send that out. Then we also, having identified the different stakeholders, we wanted to have a framework to actually think about how are we going to identify these barriers and enablers. So I use the theoretical domains framework, and as you can see on the left, there's a number of domains here that it covers. And it really helped me come up with some questions that we wanted to ask the GPs and the patients. So I'm not going to go through all of this, but just as an example, so in the knowledge domain, what's your understanding of the importance of optimizing a patient's health prior to surgery or prehab? And we did ask this emotion one, how do you feel when you think about optimizing your patient's health prior to surgery? So this helped us come up with a bit of an interview schedule that we could flexibly use in our focus groups. And we did this for both GPs and patients. And I'm not going to run you through the patient one, but it's a really useful framework. And basically what we found was that for consumers, they're totally on board with this. People who have been through surgery really understand the importance of being physically and mentally fit. An interesting finding was that actually they needed the time to prepare their home environment well. And this is something that hadn't been picked up by the project team, and something that will be incorporated into it as a result. So that was a great result there. They also felt that, nobody tells them the whole story. Nobody tells them what to anticipate. And they really want as much information as possible, as early as possible. And they saw that the GPs were the best people to do this. So some of the barriers we found were really the time. They had no idea how long they were going to wait for surgery. And so therefore they had no idea of how to get ready or prepare for surgery. And they also had nobody guiding them through this. They undertook a bit of a do-it-yourself Google approach. And similarly, the GPs had, the GP feedback aligned with this. And even more so, they said by far the biggest barrier for them is not knowing how long patients will be on that wait list before, or if indeed the referral's even been received. And a great outcome of this GP focus group was actually, now we're going to build into this project a way of letting GPs know that their referral has been received and the likely wait time. So, using this framework and doing these focus groups has really led to strengthening the features of this prehab pathway, and hopefully will lead to a much better outcome. So I'm not going to take more time. I'm going to finish here, but just say our next step will be to map these implementation strategies to deal or to address the barriers. Then we're going to test this in a quick feasibility study in 20 patients in orthopedics and general surgery. And then once we've done that, we'll then do a longer term hybrid implementation effectiveness study, where we look not only at the factors that are useful for implementation, but also the clinical effectiveness. Does it improve complication rate? Does it reduce length of stay? Does it improve the ability to deal with more patients with the same bed base? If anyone wants these slides and these resources, happy to give them to Annalise for her to pass on. Thanks so much, Annalise.
Thank you, Ecushla. That's fabulous. I think some of those in practice examples of using the frameworks is so helpful. And as you say, don't get too bogged down in how many there are, is sort of find the ones that work for you and go forward. So that's fabulous. I will just note we are running a few minutes late, but I'll just let everybody know that if you do have to leave promptly at 1 o'clock, we are recording the session, so you'll be able to pop back and watch the end of the presentations if you need. But I'll jump straight through to Peter so that we can carry on. So Peter Hibbert works in research and policy implementation in patient safety and evidence-based care. Peter is a research fellow at the Impact in Health University of South Australia and research stream lead at the Australian Institute of Health Innovation at Macquarie University. And he's going to share with us his thoughts around how implementation science aligns with continuous quality improvement to improve patient care. Thanks, Peter.
Thanks, Annalise. Can you hear me okay? Sorry, I'm just organising my slides. Thanks very much. That was great, Ecushla and Tahna. I really enjoyed both of those talks. So this talk is, and thanks to Health Translation SA, this talk kind of comes from a genuine attempt from me that someone who's been quite experienced in undertaking quality improvement projects to try and work out, well, how can implementation science enhance what already quality improvement delivers in terms of improving outcomes and quality of care. So what else can it bring, I suppose, to the art and science of what quality improvement does? So I am just going to briefly talk about why we need to improve, which I think is most of you will know. And then really the aim of the talk is to compare and contrast the two fields and try and think about what the two fields can bring to each other. And part of that is providing historical context, because they do have different histories, and it kind of explains why we've got some of the tools that we're using in both of the fields. There is a bit of an artificial kind of barrier between the fields, and I'll use the example of Ecushla's presentation later on, because it shows that there's lots of convergence going on, and things are moving closer together with both of the fields. Why do we need implementation science? Very briefly, there's a gap between evidence and what's delivered to patients. These are two studies that I've been involved in called the Care Track studies, where we measured the level of evidence-based care delivered to Australians, adults and children. And for both studies, we found that 58 to 60% of care is delivered in line with evidence. We need to take a systems approach to this, and so it's not just obviously leaving it up to clinicians for them to find out what the evidence is and translate it themselves. We need to come up with large systems-based approaches to improving how we can deliver this care. And that's where quality improvement and implementation science come in. A couple of definitions, and the first definition's already been shown today, but these definitions they're useful because they compare and contrast the two fields. So implementation science, I've just highlighted a couple of or bolded a few words that are really relevant. So it's the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practice. Quality improvement's also got that systematic word in, but it's a systematic approach to problem solving and then designing, testing and implementing changes using real-time measurement. And I think that encompasses quality improvement quite well. And I'm going to tease out a bit more of that, of those differences as we go on. So a bit of a history first off. So from the implementation science perspective, it really comes from two overlapping fields. So the first field is around behavioural and social sciences. So we've looked at the work of Everett Rogers from 1962. So this is the diffusion of innovation curve, which many of you would have seen. It's a really nice example of a behavioural science that is now embedded in implementation science. There was also the evidence-based medicine movement in the 80s and 90s. And then people like Alison Kitson and Jill Harvey and Trish Green-Haug and Grohl and Eccles, they developed what I call knowledge translation frameworks. And Ecushla's already given you that framework. But very much implementation science comes from both the behavioural science, social science fields and the evidence-based medicine movements. And many of the tools and the frameworks that we've got are behaviourally based. Ecushla already shown you this slide. Okay, so there's 100 frameworks. This is a really nice way of thinking about how to break up what is the purpose of a lot of these frameworks and which ones can I potentially use. And I'm not going to go into detail. Quality improvement, in contrast, came not out of health, but it really came out of manufacturing. Started in the 1920s with Walter Schuhart, who was working at Bell Laboratories. And he was interested in why there was variation in the quality of electrical equipment, such as telephones coming off the production line. And he started to develop quality tools associated with manufacturing. People like Deming's probably the most famous name in this space. So Deming worked in Japan after World War II. Duran was there as well. And then Womack and Jones wrote the first lean book in the early 90s. People like Don Berwick, Brett James and Paul Plessick then used those tools and brought them into healthcare. And there's there's a heap of tools that we now use in quality improvement, and some of them are illustrated in that slide. Things like process maps. So this is surgical process maps are really important in quality improvement. Ecushla actually showed a couple of process maps from her project. Small cycle tests of change embodied in Plan, Do, Study, Act cycles, very important in quality improvement. These are not just feasibility studies. These are really small scale tests of change. We're thinking about doing changes on one patient and assessing and evaluating. That's what these small scale changes mean. So they're, and you do multiple of them. And then the graph on the right, statistical process control chart from a neonatal intensive care unit in Adelaide. And this, I'll go through statistical process control charts a little bit later, but they very much are of the philosophy that when you're trying to understand a system, it's not just doing a before and after study, because a system actually changes over time, including the context. Quality improvement also use processes, so or project processes, and this is very similar to the K2A process that Ecushla talked about. And this is the quality improvement kind of mechanism that I use. So that you can see with this one, there's a lot of overlap with implementation science. This is slightly out of scope for the talk, but I thought I had to bring it in there anyway, because I've been working in patient safety for 18 years. And even though we're talking about implementation science and quality improvement, the amount of work that goes into patient safety at a health services level dwarfs both quality improvement and implementation science. So this is generally the biggest, I suppose, improvement method that around patient safety that's used in health services in Australia. Patient safety came from critical industries such as chemical and transport, and then also had a psychology background as well. And many of the tools that we use have come from those industries, such as incident management, root cause analysis, investigations, and safety culture. So, but there's three different fields that we use in healthcare: quality improvement, safety, and implementation science. There is some differences between them that can be largely explained by the history, but as time goes on, there's more and more convergence going on between the fields, and we really saw that nicely in Ecushle's talk with that process map that they had developed. The surgical process map, and that's something you classically see in quality improvement. And I would advocate needs to be in more implementation science type projects because it's a fantastic tool for understanding systems. Here's one way of conceptualizing implementation science and quality improvement, and there's a number of different ways to do it. But I think this is a reasonable one. It shows that dissemination is a field that has some overlap with implementation science, and so does improvement science, so does quality improvement. And a lot of quality improvement happens outside health services research. Okay, so it happens within health services, but not within a research paradigm. And again, I think that's very important. Here are some of the kind of differences between quality improvement and implementation science. They're both applicable where there's evidence-based practices or benchmarks or guidelines where those things exist, and you can apply either a quality improvement lens or an implementation science lens. But quality improvement is also generally used for other non-evidence-based practices, but are really associated with local problems. So it might be around your length of stay or waiting lists have blown out, or you might get a series of complaints locally that need to be managed, and that's where you tend to use quality improvement. Quality improvement's generally used with local practice. Okay, so at a ward or a department, implementation science is often applicable to multiple settings. Now, that's not always the case. I've been involved in large-scale collaboratives using a quality improvement lens. So that's it's not always the case, but that's generally how we think of the two fields. Quality improvement, the use of explicit theoretical models, it's not as important in implementation science. It's really important. It really drives the field. Again, we saw that well with the Ecushla studies, that that multiple theoretical models that Ecushla had applied and her team have applied into that project. Common tools, lots of great tools around stakeholder analysis and engagement. On the ground diagnostic tools are used within quality improvement. I'm not going to go through them, but they're really useful for engaging stakeholders. What implementation science has done has integrated a lot of techniques that come from experimental research and quasi-experimental studies, and have embedded them into the field. So that at that level, I think this is probably the most the greatest area of difference between the two fields. And then the other difference is quality improvement is primarily focused on improving effectiveness and patient outcomes. Implementation science is, as well as effective and patient outcomes, is also interested in, I suppose, the theory of implementation outcomes. So looking at the acceptability and feasibility of the interventions themselves. Last two slides. So this is what I think quality improvement does really quite well and can bring to implementation science. The first thing is the concept of the clinical microsystem, and the clinical microsystem is at the ward and the department level, and what happens locally obviously matters. With the clinical microsystem, there is this real philosophy that the people on the ground understand, know the system, and need to be empowered to change the system themselves. There's a huge set of useful on the ground diagnostic tools, things like process maps, affinity diagrams, nominal group technique, Pareto diagrams, really good for stakeholder engagement. This concept of small cycles tests of change, rather than doing one study or even just doing one feasibility study, what quality improvement does is multiple small cycle tests of change that increase in size and over time until you start rolling out your project. And then the last thing that I think QI can bring to implementation science is the measurement philosophy of statistical process control charts, which are time series charts that really say that a implementation doesn't start on day one and then finish 3 months later. It's a continuous process that happens over months and years, because the system itself changes, the intervention itself changes, and staff change. Everything changes within a system. So what happens in the first week and what happens in the first month might be different to what happens in the third month, and you need to look at it over a period of time. What can implementation science bring to quality improvement? The first two speakers have already talked about context, which is really similar to that concept of the clinical microsystem. The intervention and the context interact with each other. There's a lot of behavioural frameworks to help diagnose the system in which you're working, and there's lots of great evaluation frameworks to explain interventions. There's robust qualitative and quant research methods, and I think it's very well suited to implementation science intervention collaboratives. And then the last one, which is kind of a personal thing of mine, is I think in Australia we've got these fantastic clinical registries that are super useful and they're used really well. But I think they can be used even better by applying a implementation science lens, so the data is used in more a real-time way. A lot of those registries are used kind of retrospectively, and I think the opportunity is to use them more with real-time collaboratives. That's it. Thank you. Thanks, Annalise.
Thanks, Peter. I think that's it's a really comprehensive overview there to, you know, to really shape up the difference between the two fields, as you say, and I think quality improvement, certainly for those of us with a clinical background, is so much more familiar. So it's really you know, helpful to see those comparisons. So yes, and I'm just seeing in the chat function here as well, Ecushla noting how, you know, it's really helpful to see how the fields are evolving and what's converging and what's you know, what's separating there. So that's great. So I will I know we are a few minutes over time, but I'll just invite if anyone's got any questions for any of our speakers, to pop them in the chat, or pop yourself off of mute and ask them, or feel free to email us through if you've got anything burning, and we can you know, chase down our presenters after the fact. So just while people have a little quick think there, I will just quickly let everyone know. So we've got one more webinar as part of this series next week. So we'll be welcoming Alison Kitson and Sarah Hunter from Flinders University and Saravana Kumar from University of South Australia. Looking again, it's a next step from what Peter's just talked about, which is looking at how we're improving patient care in a health services research and health services sort of delivery context with those frameworks. So that's next Monday, and we do have recordings of today's session and the previous ones coming through on the HTSA website. So that's us if you need. Doesn't look like anyone's jumping up and down. So given the time, I will again thank Tahna Pettman, Ecushla Linedale and Peter Hibbert for joining us today. And stay tuned next week for webinar number 4.
Thank you.